Hello, everyone, and welcome to Lecture 30 in our course on general psychology. And in this lecture, we'll wrap up not only our unit on the treatment of psychological disorders, but also wrap up the course itself. So first, for this lecture, we're going to be learning about treatments for psychological disorders, like we were last time, but this time our focus will be on biological treatments. So we'll look at some drug-based approaches. A lot of biological treatments are drug-based. And we'll also look at some other means of addressing psychological disorders that are biological, but not necessarily based on medication. So these include things like surgery. And then at the end, we'll look at how effective treatments are for psychological disorders. So we already talked about psychotherapy. This time we'll talk about medication and other approaches. And we'll talk about how effective those are, either by themselves or in combination, for different disorders. So what we're going to see today is that medication isn't magic, right? It alters brain activity. So it affects neurons in some way. So we're going to appeal back to one of the early units on our course, the unit on neurons in the brain. And we'll see how medications are used to alleviate symptoms by altering how the brain functions. We'll also see there are different ways to affect the brain. So certainly different medications work on different parts of the brain, different neurotransmitter systems. But when we get on to surgical approaches, we'll see that that affects the brain also. And many times, uh, you're using a combination of biological and psychotherapeutic methods. And we'll see some reasons to believe that psychotherapy changes the brain as well. However, it can be very hard to assess how effective these various treatments are. And we'll talk about some reasons why that difficulty occurs. And when we talk about effectiveness, even if we can measure effectiveness of a method, uh, the method, of course, interacts with the disorder the person suffers from. So it's not that one particular method is good for any psychological disorder. Uh, it varies. And so oftentimes a clinician or a doctor will customize the treatment for the disorder, whether it's psychotherapy or one of these biologically based treatments. And then at the very end of the lecture today, we'll wrap up the course. We'll look back at what it is we've learned and how we might apply that knowledge as you move forward. So I'll begin by looking at some biological treatments and some drug-based treatments in particular. Now, in the previous unit, we spent some time talking about the disorder of schizophrenia. And it turns out there are medications for schizophrenia. They've been around for about 60 years. And these are called antipsychotic medications. So schizophrenia, one of the main symptoms, is what is called psychosis. If you've heard the term psychotic before, that's what that refers to, a break from reality. So these medications are called antipsychotics. And we talked last time about different kinds of symptoms for schizophrenia, most notably the positive symptoms, things that are added when you have the disorder, like hallucinations and delusions. And that's in contrast to negative symptoms, that is, things that are lost. So these are symptoms like flat affect and poverty of speech, where you lose your emotional expression and your willingness to engage in speech, respectively. So when it comes to antipsychotic medications, the first antipsychotics, what they do is they decrease dopamine levels. So they inhibit the release of dopamine. And this seems to have an effect on those that suffer from schizophrenia. And in particular, it seems to alleviate those positive symptoms. So if you take these antipsychotic medications, this first generation in particular, you'll see an alleviation of hallucinations and delusions. It doesn't really do much for the negative symptoms. It doesn't counteract flat affect or poverty of speech, but it does seem to reduce or eliminate hallucinations, for example. And the positive symptoms are, in many ways, the most disruptive. However, it turns out that though that initial treatment led people to believe that it was as simple as schizophrenia equals too much dopamine. And it turns out that's not quite right. So certainly reducing dopamine will decrease those positive symptoms, but it turns out different parts of the brain use dopamine. And it's actually negative symptoms that are caused by too little dopamine in some areas. So you have sort of a contradiction. Across the whole brain, some areas exhibit too much dopamine, and you get positive symptoms. Some areas have too little, and you get negative symptoms. And this is a very hard thing to treat because uh, drugs, at least so far, aren't as specific as we need them to be. So if you just apply a drug that increases dopamine everywhere, you're going to start getting positive symptoms. If you apply a drug that decreases dopamine, you can exacerbate those negative symptoms. And so you're sort of caught between the two. Later on, after that first generation of antipsychotic treatments came around, you had a new generation of antipsychotics. They're often called the atypical antipsychotics. So you have these two different categories. And I should say right away, your book doesn't mention this, but there is quite a bit of controversy as to whether this is a useful categorization, whether there are really two distinct categories. Many people think they are not, that these drugs exist on a spectrum. So I should preface by saying that. Uh, what differentiates the typical and atypical antipsychotics is really how much they affect dopamine versus how much they affect serotonin, which is one of our other neurotransmitters. So the typical antipsychotics, the first ones to be developed, tended to affect dopamine more. They decrease dopamine release. Whereas the atypicals affect serotonin more. So you're talking about a ratio or a balance between one neurotransmitter and the other. So this is not a diagram from your book, this is from a different source. But what this graph indicates, the y-axis, is how much the drug affects a given neurotransmitter. The x-axis is different drugs. And so what I've circled here with these boxes, these magenta bars, are how much the typical antipsychotics affect dopamine. And these green bars are how much they affect serotonin. So you can see from this group, they affect dopamine as much or more than they affect serotonin. So these are the typical antipsychotics. The atypicals, you'll see that green bar is higher. And so that's the effect on serotonin, and we can see it's higher than the effect on dopamine. That's what makes it an atypical antipsychotic. Another one, same group, atypicals. We see on the right here that the effect on serotonin is much bigger than the effect on dopamine. And again, how useful this categorization is up for debate. But the fact is that the typical and atypical categorization, if it is useful, says something about the relative effect on dopamine and serotonin. But the effects aren't entirely good. Even if you eliminate positive and negative symptoms, there are still side effects. And one of those side effects is called tardive dyskinesia. And this can happen after prolonged use of an antipsychotic drug. From this picture in the top right, we see a woman exhibiting tardive dyskinesia. And this is characterized motor movements, so unwanted or stereotyped movements that the person can't really control. Often this is in the face, so we see this woman grimacing, and that's not something she's using to express emotion. These are uncontrollable movements that are produced as side effects of antipsychotic treatments. Another group of psychological disorders are, of course, the anxiety disorders. And so here, anti-anxiety medications are often used. The most common are the benzodiazepines. So the benzodiazepines include famous drugs like Valium, which you see down here at the bottom of the slide. So Valium is a depressant, and in particular, it's a benzodiazepine, sometimes just called a benzo. And the way it works is by enhancing the activity of the neurotransmitter GABA. So GABA we see pictured here. And GABA is a neurotransmitter that decreases the excitability of the nervous system. So when you increase GABA or increase its effectiveness, now what you're really doing is quieting down the nervous system. You're making neurons less excitable. They're harder to activate. And so what does this do? Well, it relaxes the person. So it reduces anxiety by reducing the amount of activity going on in the nervous system. They're also used as sleep aids, sometimes called hypnotics. And in many cases, the benzodiazepines, it's a matter of dosage. If you take a little bit, it can act as an anti-anxiety medication. If you take a lot, it can put you to sleep. And this is true of many depressants. So benzodiazepines can also be used as sleep aids, but GABA agonists, that is, drugs that enhance the activity of GABA, in general are both anti-anxiety and sleep aids. Of course, there are other psychotherapeutic drugs beyond antipsychotics and anti-anxiety medications. Another really common class of medicine in this category are the antidepressants. And what this graph on the right shows, this is from your book, shows the rise of antidepressant use in the last few decades. And this graph happens to break it out by sex. We see that antidepressant use is more common among females than males, and that's not surprising. Women are at a higher rate for suffering from depression, and they're also at a higher rate for seeking out treatment. So it's not surprising that they are more likely to use antidepressants than men are. Again, the degree to which those are biological or cultural effects remains to be seen. In any event, antidepressant use is on the rise. And antidepressants, the way they work is by increasing levels of the neurotransmitter serotonin. So serotonin is a neurotransmitter that's involved in mood. And we think that depression is the result of too little serotonin being around. And so what these drugs do is increase serotonin levels. Now there are different kinds of antidepressants. The first generation are what is known as the MAOIs. You may have heard that term, especially in pharmaceutical commercials. MAOIs are monoamine oxidase inhibitors. Now that's a long name. So what does it mean? Well, I've circled it here on this diagram. But what monoamine oxidase inhibitors do is they inhibit, that is, they keep it from working, the enzyme monoamine oxidase. So that's an enzyme that exists in your neurons, and it breaks down neurotransmitters like serotonin, but also norepinephrine and dopamine. So that's what the enzyme does. It destroys those neurotransmitters. Well, if you inhibit that enzyme, if you keep it from working, then you're going to see an increase in those neurotransmitters. And when it comes to serotonin, that is what you want. You want to increase serotonin levels and alleviate the symptoms of depression. Now, the trouble with the MAOIs, and they were the first antidepressants to be developed, the trouble is the side effects. Because you're affecting three neurotransmitter systems at once, there are a lot of unwanted side effects with MAOIs. And the story of antidepressant development is really the story of getting more and more specific with regard to what it is you're targeting. So the second generation were what is known as the tricyclics. And they're called that because of their chemical structure. They've got three rings. They're called tricyclics. But what they do is they don't affect monoamine oxidase. They don't work on an enzyme. They block a transporter molecule. And what transporters do is move neurotransmitters back into the neuron by a process called reuptake. And that's something we covered way back at the beginning of the course in our unit on neurons. So what the tricyclic antidepressants do is block neurotransmitters from being taken back into the neuron. And in particular, the neurotransmitters that are affected are serotonin and norepinephrine. So a little more specific than the MAOIs. So that's good. You get fewer side effects. The third and current generation of antidepressants are the SSRIs, the selective serotonin reuptake inhibitors. So these just affect the reuptake of the neurotransmitter serotonin, which is the neurotransmitter we want to be affecting. If we want to affect mood, we want to alleviate depressed mood. So these are more specific. They tend to have fewer side effects. And again, that is the timeline of development, getting more and more specific drugs that have fewer side effects. And so when it comes to the effectiveness of these drugs, at first there were studies coming out saying they're definitely more effective than placebos are. We'll talk about placebo effects at the end of this lecture. It's a little controversial now because it turns out pharmaceutical companies weren't necessarily publishing all of their results. So obviously they want their drug to work, and whether consciously, intentionally, or otherwise, probably intentionally, they were withholding certain findings to make antidepressants look more effective than they actually were. So it's a little controversial. We still think that antidepressants are more effective than placebo, so they're still doing something. But it's not a huge effect. It is not a cure-all, to be certain. Another group of drugs are the mood stabilizers, and these are used for bipolar disorder. So we talked about bipolar disorder in the previous unit. Uh, Periods of depression and mania used to be called manic depression. And you might think you could administer antidepressants and at least alleviate the depression part of bipolar disorder. But it turns out if you do that, you're at a higher risk for those manic episodes. And so you have to take a different route. Rather than apply drugs that would alleviate either depression or mania, you use mood stabilizers. So these keep both effects from happening, or at least alleviate them to some degree. And these are drugs like lithium, I think probably the most famous one. There's another one called valproate. But these regulate the person's mood with regard to both mania and depression. There are also natural products that some people use as biological treatments for psychological disorders or psychological issues. The trouble here is that dietary supplements and herbal supplements aren't regulated by the FDA. And there are laws that govern what you can say about a supplement if you're not calling it a drug. If you say that it is for a certain disorder, for example, then the FDA has to approve it. But if you just say it's for general well-being, then that still counts as a supplement, and you don't have to go through medical testing, drug testing, to see whether it's effective or not. So herbal supplements, you can pretty much claim anything as long as it's vague, and you don't have to prove it. So we don't really know much about the effectiveness of a lot of herbal treatments. And be aware that some herbal treatments are actually harmful. Some natural treatments are actually harmful. So there are certain ones you should avoid, and keep that in mind. The ones I'm talking about here today don't seem to be in that category, but there are some that certainly in high doses can be harmful. And here I'll mention a common mistake that people make, and that is what's called the appeal to nature, or the naturalistic fallacy. So this is an error in logic. It's a logical fallacy. It's a common mistake. And that is the idea that if something occurs naturally, that is necessarily good for you. That natural products are better than synthetic ones for you. And that's a mistake. It's not the case that the reverse is true. It's not necessarily that synthetic compounds are better for you. Uh, it's on a case-by-case basis. So a particular compound may come from nature, or it may be synthetic, and it could be helpful or it could be harmful. Just because it's natural doesn't mean it will help. There are plenty of naturally occurring substances that will kill you. And of course, if there is a naturally occurring substance, if we synthesize it, they are chemically the same. So it doesn't matter which one you take. So just be wary of that. Don't fall into the trap of thinking that just because something occurs naturally, that it's good for you or better than the synthetic version. Again, synthetic or naturally occurring doesn't really matter. What matters is the evidence for what the product does. Here I'll mention a couple that are thought to be related to depression, and those are St. John's wort, which we picture here. So wort is just a type of plant, and the omega-3 fatty acids. St. John's wort is an herbal product. It's readily available, and the evidence is mixed as to whether it alleviates depression or not. Just like with antidepressants, you have to worry about placebo effects. So people think they're taking something that's going to help them, and oftentimes their symptoms get reduced. And it doesn't necessarily mean that the product is effective. So the evidence is mixed on St. John's wort for omega-3 fatty acids, and these are compounds that are found in things like nuts, avocados, fish, certainly, which I've pictured here. There's some reason to think that Those omega-3 fatty acids might reduce depression. And there are correlational studies. Countries with people that tend to they eat more fish, have lower rates of suicide and depression. Again, whether that's causative, we're not quite sure, but there's some evidence for it. But those are two naturally occurring substances that people are starting to pay attention to, and some people take as a biological treatment. Uh, there's also phototherapy, which is light therapy, having light shined on you. So phototherapy is not a medication, obviously, but it falls under a natural treatment. The idea is that being exposed to natural light can alleviate symptoms of depression, and in particular, seasonal affective disorder, which is a disorder we talked about in the previous unit, where low light levels, especially during winter, tend to bring about the onset of depressive symptoms. The idea here is that light can sort of trigger your brain uh, to stop exhibiting those depressive symptoms. That you'll have day and night cycles or light cycles that are more akin to what you see in summer, where seasonal affective disorder uh, doesn't exhibit symptoms. So phototherapy, a natural treatment. So that's why we put it here under herbal and natural products. So as I mentioned before, not all biological treatments are necessarily medication-based. There are other interventions as well. And these are often used because medication doesn't work for everyone. We don't necessarily know why, but many people don't respond to their psychotherapeutic medication, or they have side effects that are so severe that they don't want to take the medication. And so medication isn't always effective, and the side effects can be severe. Sometimes people think they're even worse than the disorder itself. And so that leaves the person with only a couple ways to turn, and then that is to psychotherapy, which is not effective for all disorders, uh, or to other biological approaches. And these are approaches often that alter brain activity. So disorders, of course, uh, carry symptoms. They could be thought related, they could be emotion based, they could be behavioral. But all of these things, as far as we know, are brought about by activity in the brain. So the idea here is that these treatments alter brain activity, and there's evidence that they do alleviate the symptoms of the disorders they're designed for. So one is ECT, which is electroconvulsive therapy, and this is applying electrical current directly to the person's scalp. So they are generally under anesthesia for this. They do not experience the shock itself, and there's some effect of short-term memory loss. But ECT is often used for depression that isn't responding to therapy or to medication. And so electroconvulsive therapy is literally applying electricity to the brain and altering brain activity that way. Another method is transcranial magnetic stimulation, which I mentioned way back in our unit on psychological methods. So this is a method that applies a magnetic field to the brain, and we don't need to get into the physics, but the equivalence between magnetism and electricity causes electrical currents to be altered in the brain. And so this is usually applied to the frontal lobes of the brain. It's not terribly specific in terms of location, but it also is used to treat symptoms of depression. And there's some evidence that it works. There's also deep brain stimulation. So the first two methods that I've mentioned here are non-invasive. You don't have to break the skin to use these methods. Deep brain stimulation is the implantation of a permanent electrode. And so here there are electrodes that are implanted in the brain. They run more or less continuously at intervals, and they're controlled by kind of like a pacemaker that's implanted under the skin. Uh, and so here, this is a different method. You're applying electrical currents in very particular locations. So most commonly, this has been used for Parkinson's disease. So Parkinson's is the result of the death of dopamine neurons in the brain. And by activating, by stimulating dopamine neurons electrically, the idea is that you can cause extra dopamine release. You're sort of compensating for the death of dopamine neurons by increasing dopamine activity by stimulating the neurons directly with these electrodes. Since then, it's been shown to be useful for OCD, obsessive compulsive disorder, that again isn't responding to medication. This is a surgical procedure. It is invasive. It involves a permanent electrode and damaging the brain a little bit. So you have to be a little wary. It's often a last resort for OCD patients. And so that is a relatively new use for deep brain stimulation. Also for depression that's not responding to medication, therapy, other treatments. DBS seems to be an option that can help alleviate symptoms of depression. So again, all of these things are altering activity either by applying electricity or by applying a magnetic field, which induces electricity. These are all ways of altering brain activity. The alternative is to alter brain structure. And this is what's often called psychosurgery. So these are diagrams of the brain from a different book. But one famous surgical method is the frontal lobotomy. And this thankfully is no longer in use, although it was until only a few decades ago, really. And so this was developed in the earlier part of the 20th century as a means of addressing schizophrenia. So by severing the connection between the frontal lobes and the rest of the brain, the person became less volatile. They didn't exhibit those positive symptoms. But it turns out it really just made them docile by removing a large part of the brain. So they were easier to manage, but they really lost their personality. They would often not communicate, or they would lose some aspect of who they were. Uh, and so frontal lobotomies are really pretty devastating. Sure, they alleviate the symptoms and make the person easier to manage, but the person is often in a non-responsive state. And so this is no longer used. For OCD, however, there are a couple of surgical options. One is called a cingulotomy, and the other is called an anterior capsulotomy. So these are both intentionally creating lesions in the brain, so destroying brain tissue. In the cingulotomy, I've circled this area here. So this is a diagram of the brain if you sliced it down the middle into left and right halves, and then you looked at the inside of the right half. Uh, there you can see the cingulate gyrus and the corpus callosum. So these are internal structures of the brain. They're still part of the cortex, but they are on that inner surface. So there's evidence that if you destroy part of that cingulate gyrus, that's why it's called a cingulotomy, that you can alleviate symptoms of OCD. The anterior capsulotomy, you are destroying part of the basal ganglia. And so the basal ganglia, we've already seen, is involved in OCD. If you're using deep brain stimulation to alleviate OCD, that electrode is often in the basal ganglia. So here you're inducing a lesion in the basal ganglia. You're destroying that part of the brain. Not all of the basal ganglia, it's a big structure, but part of what's called the internal capsule. We don't need to go into the details of the neuroanatomy. But these are both surgical options that seem to alleviate the symptoms of OCD. So those are some biological treatments, some of them medication-based, some not. But whether they're biological treatments or psychotherapy, the question is how effective are these treatments? Do they alleviate or eliminate the psychological disorder they're trying to treat? And this is a trickier question than it sounds, because there are a number of reasons that people may show fewer symptoms or may seem to have recovered from the disorder that have nothing to do with the treatment itself, that aren't specific to the treatment. One is what's called natural improvement. And this is when a person just happens to get better when they're undergoing treatment, not because of the treatment, just happens to coincide. And this actually happens because people tend to seek treatment when symptoms are at their worst, when they become intolerable. And so naturally people fluctuate in terms of the severity of their symptoms. And so if you go in for treatment when things are at their worst, you sort of have nowhere to go but up. And so you're bouncing around your average in terms of behavioral symptoms or in terms of mood. And so if the symptoms get better, it's not all that surprising because you went in at a time when it was really severe. There are also placebo effects, and we've all heard of placebo effects, but what are they? So this is when just thinking that you're on a treatment actually helps with the disorder. So it's not something specific to the treatment at all. It's not what a drug does, or it's not the particular methodology of the therapy. It's just that you're doing something about your symptoms. And people tend to become optimistic about improving symptoms. And so they do actually show a tendency to get better. Their symptoms aren't as bad anymore after treatment. Again, not because of the specific treatment, but because somebody was doing something about the problem. It elevated their mood. It made them more optimistic. And so just the fact of being on what you think is a treatment can improve the symptoms, even if the treatment doesn't actually do anything. And then finally, you can have error, what's called errors in the reconstructive memory. So the patient certainly wants to get better. Oftentimes, these things can be very expensive. So they don't want to have wasted their time and money. They may want to please the therapist or the doctor. And so they will often report their symptoms are better when objectively, if you measure the symptoms, they really haven't changed. So what causes this? Well, the person recollects the symptoms as being more severe before the treatment than they actually were. So they have a pretty good picture of what their symptoms are currently like, but they've reconstructed their past symptoms, the severity of those symptoms, incorrectly. So that's why it's an error in reconstructive memory. The person has misremembered how bad the symptoms were to start with. And so there, the improvement didn't really happen. So they think they recovered, but in fact, their symptoms have not gotten any better. It's also worth noting that treatment itself can cause symptoms of the disorder or certainly side effects. And this brings us to what's called iatrogenic illness. And this is where the treatment itself causes the disorder, causes symptoms. So if a person thinks they have a problem, goes in for therapy, and the therapist diagnoses them with a disorder, they may start exhibiting more symptoms of that disorder, even if they didn't have the disorder in the first place. So that would be an example of iatrogenic illness. Certain medications sometimes don't have the effects you think they're going to. They can have what are called paradoxical effects. They bring about the opposite of what you expected. So they can actually cause symptoms rather than alleviate them. Also, when it comes to behavioral programs, they don't necessarily bring about illness, but they can bring about the very phenomenon they're trying to eliminate. And this is true for things like the DARE program, which is an anti-drug program popular in schools, Scared Straight and boot camps for conduct disorders, post-traumatic relief efforts called critical incident stress debriefing. And you don't need to memorize those acronyms or anything. But the point here is that these programs are well intentioned. They're trying to keep people from exhibiting symptoms of PTSD, or they're trying to keep people from abusing drugs. And yet, studies show that many of these programs actually increase drug use in the case of DARE, or increase the symptoms of trauma in the case of CISD. And this is a table, by the way, from the original paper that your book refers to. It's probably too small for you to see it in this video, but of course you can always look at the slides that are available. So you can see a number of programs that bring about the very phenomenon they're trying to avoid. And so we have to be wary. We always have to do our research on the effectiveness of programs. We can't just assume that a program of treatment is effective. We have to prove it. And so historically, there have been a number of programs that either didn't work or actually made things worse. So those are some issues we need to be aware of whenever we're trying to assess the effectiveness of a treatment. The question, of course, is we have psychotherapy and we have biological approaches, medication in particular. Which one is better? Which one should we use? Of course, it's also possible that both should be used simultaneously. The combination is the best approach. And the answer is that it depends on which disorder you're talking about. So for things like schizophrenia and bipolar disorder, a medication seems to be far more effective than psychotherapy. So these are severe disorders with severe symptoms. And medication seems to be a necessary component for those. For panic disorder in particular, this is a figure from your book, it seems that cognitive behavioral therapy, a form of psychotherapy, is really about as good as medication. And both of those are better than nothing, or better than a placebo. Uh, but it turns out the combination, combining them, doesn't really get you anywhere. So one or the other is helpful, but putting them both together doesn't necessarily get you extra benefit. So it's a little counterintuitive. You would think that if one helps, putting both together should be even better, but it's not necessarily. Other mood and anxiety disorders, uh, for the most part, psychotherapy seems to be about as effective as medication. So again, it depends a little bit on the disorder. For depression, the combination seems to be more effective. This figure in your bottom right is from the original paper that your book refers to. But you can see a number of disorders here that, depending on which disorder you're talking about, it could be psychotherapy that's more beneficial, or it could be medication, or it could be both. And so, again, we have to be a little careful. The research is not always ironclad because of the issues I talked about in the previous slide. But in general, for mood and anxiety disorders, psychotherapy seems to be about as effective as medication. Which leads us to the question, uh, are these two things doing the same thing in the brain? Are psychotherapy and medication, if they're both effective, are they affecting the brain in the same way? So this is a figure in the bottom here from your book, from a research study looking at people with social phobia, so a form of anxiety disorder. And so again, medication tends to be about as effective as psychotherapy here. And so they had patients that had been undergone one or the other, and then looked at brain activity when these people were told they'd have to give a public speech. Now, for someone with social phobia, that is a very frightening prospect. And so looking at the brain's response to being told that you're about to give a public speech tells us something about what effects psychotherapy and or medication are having on the brain. And it turns out that for those people where treatment was effective, you saw decreased activity in the amygdala and the hippocampus, which are both important for memory and emotional processing. So you saw a similar pattern of activity for people that had been treated with either psychotherapy or medication, in particular those people for whom those treatments were effective. So we can see that yes, there is a similar pattern of change in brain activity, whether you undergo psychotherapy or medication. And one issue when it comes to medication is who should be able to prescribe it. And now, in most locations, you have to have an MD, a psychiatrist, prescribe medication. In some instances, a psychotherapist, a psychologist who is licensed can also prescribe medication. So that's one of the big debates, is how widely we should allow therapists to prescribe medication, what sort of credentials they should have to have. And there are pros and cons. If someone would benefit from medication, then you would want that person to have medication that's accessible. So maybe they don't have a psychiatrist in their area, or maybe they can't afford a psychiatrist, but they could go see a psychologist. And so maybe you want that psychologist to be able to prescribe medication. At the same time, psychiatrists undergo extra training. So they may have more knowledge about things like side effects, about the biological basis for how the medicine works. And so there's this tension between making medicine available to those that need it and keeping it out of the hands of those that aren't qualified to hand it out. So there is no easy answer to that debate, and it goes on. So that will do it for this unit on treatment of psychological disorders. And that will do it for the course. So I'd like to look back on the course and see what we've learned. So first, the topics we've covered. Uh, we've spent a fair amount on the history of research and theory in psychology. And some of that research and some of those theories have held up quite well over the years, and some have not so much. But it's important to acknowledge both. Psychology is a science, and part of being a science is that you have to acknowledge and take into account new evidence as it comes up. And so certain theories that have no longer that are no longer accepted, uh, oftentimes are no longer accepted because evidence has come to light that they are not accurate. And so it's important to understand psychology as an evolving discipline, as a scientific discipline, where new information is coming up all the time. So this course reflects our current knowledge of psychology, but that information could change over the years. And that is always true of a science course. Science and our knowledge of science is never static. Hopefully, I've also given you an appreciation of the different components of your mind, of your psychological function. So we've talked about things like the senses, learning and memory, emotions, intelligence, decision making, consciousness. And so these are all very important parts of our psychology. You would not be the same without them. And generally, we don't give them much thought. We tend to take them for granted. But hopefully now you have better insight as to how important these things are. And I've also repeatedly emphasized the role of the brain. And the brain has taken on an increasingly big role in our understanding of psychology. We've only really been studying the brain for a few decades. But while we don't know everything, we certainly know quite a bit about the brain and how it relates to psychological function and our psychological experience. If you lose part of the brain, you will probably lose some aspect of your psychological function. So it's very important. Be sure to take care of your brain. But hopefully it's also come through that we don't know everything. There's still a lot to be learned about the brain. And so research continues on how the brain works, how different parts of the brain communicate with one another, and how the brain gives rise to complex psychological phenomena. We've also talked about complex psychological phenomena in the context of the self and others. We had a whole unit on social psychology, how we relate to other people, how we understand other people, and the self, personality, emotional processing. So now that we've seen these topics and looked at some of the research that has gone into these topics, you'll hopefully have more insight both into yourself and into others and your interactions with other people. And of course, we just spent 2 units on psychological disorders. And there's been a fair amount of research on these and the treatment of psychological disorders. We certainly don't know everything. Certainly when it comes to causes, some disorders are less well understood than others. But at the very least, I hope you come away from these units understanding that these psychological disorders are not mysteries. They're not magic. That they are based in the brain. And so there are ways to treat them. There are ways to change behavior, to change thoughts, to change the brain in such a way that these disorders can be alleviated. And hopefully this course may also help reduce the stigma of mental illness and mental health services. In terms of our approach to the course, hopefully you've been engaging those critical thinking skills. So I've mentioned, even in this lecture alone, several controversial topics. So they are controversial when it comes to what we should do in terms of policy. They're also controversial with regard to the research. So studies don't always come up with one ironclad, unquestionable answer. Findings can be ambiguous. Sometimes different studies will contradict one another. And so it's important to understand that's part of the scientific process. So you have to think critically about the evidence. What conclusions can you draw from the experiments and from the research that's been done. And hopefully those discussions have also been helpful in this regard, that it's made you think about some of the topics we've covered in this course, and so that, again, you may consider them in the future. We've also covered a lot of branches of psychology: social psychology, for example, personality psychology, biopsychology, the study of the brain and biological processes. Uh, and so there are a lot of different areas in psychology, and hopefully you appreciate that. And there are a number of scales as well. Things like behavior and consciousness, very big scale. Things like the senses, smaller scale, more specific. Activity in the whole brain, or what's going on in individual neurons. So these things all affect psychological function. And it's important to understand that psychology occurs at every one of these scales, from the microscopic up to the scale of a society. And finally, I hope that you can see the relevance of psychology to your daily life. Now that we've covered these topics, now that maybe you've thought about some of these topics and the research that's gone into them, that now you can appreciate why it's relevant to your everyday existence. Maybe it'll help you gain insight into your own emotional experience. Maybe it will help you relate to someone else. Maybe it will help you understand someone that has a psychological disorder. And maybe it'll help you recognize errors in decision making. So all of these things are things we've looked at in this course. And I hope now, whether you move on in psychology or another field, that you can appreciate the importance of psychology when it comes to who we are as human beings. And so with that, I will end the course. Good luck on the last exam. For those that are graduating, congratulations. And for those that are not, have a good break. And I hope to see you in psychology courses in the future.